Okay, so I'm going to finish up by talking about other shoulder pathology outside of the rotator cuff. Disclosures: I'm a consultant for BioClinica, book royalties from Elsevier, grant from AIUM, and research equipment from Harvest Technologies. So we're going to cover 8 areas. First, these 4 areas, beginning with impingement syndrome. So we're talking specifically about subacromial impingement. As you know, there's this enclosed space here beneath the coracoacromial arch where the supraspinatus will travel through the space. Also, the bursa is located in this space. So basically, anything that can narrow this space, or if the tendon is enlarged, can cause secondary impingement. So you could have an enthesophyte, a spur under the acromion. You could have an AC joint osteophyte, just a number of 2 potential pathologies that can narrow the space, predisposing to tendon abnormalities such as tendinosis and tendon tear. So basically, many people feel that this is a clinical diagnosis, but nonetheless, this is described in the ultrasound literature as how to diagnose subacromial impingement. So basically, what we're looking for is the effect of this enclosed space on the bursa. So basically, if a person abducts their arm and fluid is pooling at the lateral acromion, that implies that the space is so narrow that the bursa cannot fit under there. So it's basically acting like a squeegee and pushing the fluid so that it doesn't go under the acromion and it becomes visible at the lateral acromion margin. So basically, there are a number of ways of doing this. You can actively elevate the arm or abduct the arm. Some people describe internally rotating and then also more anterolateral. But I find just moving lateral and abducting the arm seems to see most of these. There's also uncommonly subcoracoid impingement, where basically you might see fluid moving within the subscapularis recess around the subscapularis muscle tendon and the coracoid. So I'm going to focus on subacromial impingement.